So, the patient we're about to treat is a 57-year-old male grade school teacher with relapsing remitting multiple sclerosis. He was admitted into an acute care facility with a diagnosis of pneumonia. They also reported that the patient seemed weaker in both lower extremities. The patient also reported that he had increased tingling in his left hand and numbness on the left side of his face. They treated his pneumonia with a 5-day course of antibiotics, but the patient continued with weakness and decreased level of function. He then was admitted into our acute intensive rehab. The patient has been living at home for several years with occasional help from his sister and a home health aide during his exacerbations. He lives in a 2-bedroom, 1-patio home with 1 step to get in the home and a ramp in the garage with a 6-inch rise from the floor to the kitchen. The patient presents with a wide-based ataxic gait and bilateral upper extremity and tension tremors with mild limb ataxia. The patient can be euphoric at times and is easily depressed and cries easily. His speech is dysarthric and slowed and sometimes slurred due to his diagnosis. His tolerance to activity is up to 10 minutes before rest is required. Both lower extremities present with moderate extensor spasticity, grade 2 on the Ashworth scale. The patient is minimal contact assist with bed mobility and with his walker. He requires supervision with a manual wheelchair for distances up to 150 feet and requires a lap belt due to the extensor spasms. He's able to maintain balance independently for up to 5 minutes with, static sitting balance up to 5 minutes with minimal posture tremor. The patient is able to maintain static standing in the parallel bars with meniscus for up to 3 minutes. He tends to keep his knees in hyperextension or stiff into extension. He is unable to weight shift without having, or step without having bilateral handhold support and is max assist with stairs. The 2 impairments I want to treat today are his extensor spasticity in both of his lower extremities and the weight shifting with the bilateral handhold support. I want to address the extensor spasticity in his lower extremities because that is a safety risk for when they are doing transfers, and it limits his functional mobility as far as like bed mobility, dressing, walking, and wheelchair propulsion. I want to address the bilateral supported weight shifting because the patient is max assist with stairs and minimal contact assist with his walker, and I feel that addressing the weight shift will help reduce the assistance with the walker and help increase his balance and help his ataxic gait and help with stair negotiation. The intervention I am going to do to address his extensor spasticity is rhythmic rotation of his lower extremities. First, I'm going to try and do passive, and then active assistive, and then active. And the other intervention I'm going to do is weight shifting with bilateral handheld support and then progress to unilateral handheld support. I chose to do these interventions because he is just recovering from pneumonia, and these interventions aren't as fatiguing as stairs or walking would be, but they will still address his limitations.